All right. If we don't start, we don't finish. Somebody I know says, welcome. I'm Eli Gelfand, for those of you who don't know me. Silo, first-year fellow. I have to introduce myself. Thanks for being here. I have a short introduction to the lecture series, and I tried to put together a short introduction for Dr. Kittleson, but it didn't really work out since her resume is so extensive. It's really a pleasure to see so many colleagues and friends, and there's a lot of people in Zoom, which is always also gratifying. A lot of people from out of town are tuning in. We started this lecture series last year through the generous funding of many patients and families, and I chose to name the series after my parents, Vladimir and Anna, and I made them a promise last year not to talk about them too much, and so I'm keeping that promise today. I will say a couple things because I can't restrain myself. They're both accomplished basic scientists, and I do remember that early in my medical career, which I can say now, I've been excitedly talking about various trials and meta-analysis and general happenings in the hospital, and I think they must have implicitly just chuckled at the imprecision of all of it. Being basic scientists, statistical p-values and so forth notwithstanding. And I think perhaps with years, I've acquired a deeper appreciation of this imprecision and how important it is in clinical care to not just care about the hard data, but to learn from others, more senior people, and I think much more so, more sort of junior people in trainees, about this other aspect of medical care that's not just hard science. Some people call it the voodoo of medicine or whatever you want to call it. I call it the art of clinical care. And I think it's hard to describe, but you know it when you see it. And you know people who do it very well. And then you know people who are still learning how to do it. And so that's what the series is about. And we've designed it to invite accomplished clinician scientists, people who are uniformly known to be good teachers, thought leaders, to come and share their piece of their art with us every year. And so I'm very honored today to introduce and welcome Dr. Michelle Kittleson, who I've known as Dr. Michelle Pinto a long time ago when we were residents together across the street, where she was my junior resident, I think we figured yesterday on the BMT service, which we've both attempted to forget as soon as we could. She's the associate professor at Cedars-Sinai in Los Angeles. She's the director of heart failure research and also the director of medical education and heart failure and transplantation at Cedars-Sinai. She has a modest resume of having earned an undergraduate degree at Harvard and MD at Yale. Then she was a resident at the Brigham, and she was a fellow at Hopkins, and she also earned a PhD at the Bloomberg School of Public Health there. Her accolades are too numerous and would take most of the hour to list, but just a few. She served on the writing committees for multiple ACC/AHA guidelines, authored over 300 publications, chaired multiple expert opinions, and is importantly a 2025 recipient of the ACC Distinguished Teacher Award. Many of you have now purchased and read her book, Mastering the Art of Patient Care. I can't think of anybody more accomplished to give this talk this year. And she's widely admired by the trainees and colleagues and has about, I checked, Michelle, 41,000 followers on Twitter or whatever it's called now, which I think mathematically puts her squarely between Taylor Swift and Robert Gersten, right in the center. She's going to talk to us about heart failure with preserved ejection fraction. Welcome.
Oh my gosh, thank you for the warm welcome. I'm totally delighted to be here. And I just wanted to clarify, when he said junior resident, he means I was his boss, Right. He was my intern. All right. A relationship which shall remain evermore for decades to come. Okay, let's dive in. Approach to heart failure with preserved ejection fraction. I have no disclosures. No one pays me to say anything. Everything I say comes straight. No chat GPT involved. So much of what I'm going to tell you today is going to come from these documents, the 2022 heart failure guidelines, for which I was on the writing committee, as well as a 2023 expert consensus statement on HFpEF, which I chaired, as well as one on obesity and heart failure that came out earlier this year. But you're looking at these statements and you're saying, wait a minute, there's another really important one out there. Why isn't she talking about that one? And yes, there is another hugely important one that was written by your expert in heart failure, with your international expert in heart failure with preserved ejection fraction, the awesome Dr. Jennifer Ho. So I will be pulling on much of her wisdom as we go through this talk. I also think there's nothing more interesting than talking about a patient. So let's begin with a case. A 72-year-old woman presents with a 2-week history of shortness of breath. She has hypertension, paroxysmal atrial fibrillation, and osteoarthritis. Her medications include rivaroxaban, chlorthalidone, amlodipine, and ibuprofen as needed. On exam, BMI 31, heart rate 68, blood pressure 142/88, JVP 10 centimeters of water, lungs clear, heart S4 gallop, 2+ edema. Her echo shows mild increased LV wall thickness, normal EF, mild aortic stenosis, and mild pulmonary hypertension. So if this patient walks into your clinic, dyspnea, edema, preserved ejection fraction, you have to go through the dreaded differential diagnosis. And this was one of the things that was the most challenging to me in medical school, because patients don't present with diseases like we read about in the first and second year of medical school. They present with symptoms, and learning to track backwards from symptoms to diseases is one of the most challenging things we can do. And I had this incredible mentor in medical school who said, always don't memorize unless you're going into rheumatology. Otherwise, organize your etiology by anatomy and pathophysiology. So when you think about dyspnea, it's either the heart's fault, the lungs' fault, or it's coming from somewhere else. And if it's the heart's fault, it's either the muscle, the vessels, the valves, the pericardium, or the electrical system. And if it's the lungs, it's the airways, the parenchyma, the pleura, or the vasculature. And if it's something else, it's, well, the oxygen carrying capacity of the blood is low with anemia, or the lungs can't expand with neuromuscular disease, or it's the perception of dyspnea from deconditioning or anxiety. But of course, as cardiologists, we're focusing so much on the cardiac causes of dyspnea. And you can do the same exercise for someone presenting to your office with edema. So what are the two principal causes of edema? Increased capillary hydrostatic pressure, decreased capillary oncotic pressure. And then you think about hydrostatic pressure. Where would that come from? The heart, the muscle, the valves, the pericardium, the liver, the kidney, or something anatomical like venous insufficiency, pregnancy medications. And if it's decreased capillary oncotic pressure, maybe not taking in enough protein, maybe not making enough protein, or maybe losing protein through the liver or the GI tract. And this exercise is one I do a lot with trainees. All the experts in the audience don't really need this, but I think it's important to go back to those first principles, because you can take an overwhelming list of causes and organize them in a way that is no longer overwhelming and that you're unlikely to forget something. So going through this, and if I asked you, for this older woman who's overweight and hypertensive with dyspnea and edema and a preserved ejection fraction, what's the most likely diagnosis? You all being excellent test takers would say, of course, it's HFpEF. That's the name of the talk. And I'd say yes. But cardiac amyloidosis, one of my favorite other diagnoses, is always possible. We'll talk on that in a few slides. Of course, hypertrophic cardiomyopathy makes no sense here, right? That's defined as unexplained increased LV wall thickness, and hers is explained by hypertension. 72 is a little old for diagnosis. Aortic stenosis doesn't make sense. Her aortic valve's not that bad on echo or examination. Don't forget about the importance of the examination. And pulmonary arterial hypertension doesn't fit at all either, because her pressures aren't that high. She doesn't have the right demographic for classic group 1 pulmonary arterial hypertension. So this all seems very straightforward. And when we think about heart failure with preserved ejection fraction, we can go back to first principles of the universal definition of heart failure, which tell us that to diagnose heart failure, you must have symptoms and or signs of heart failure caused by a structural and or functional abnormality corroborated by at least one elevated natriuretic peptides or objective evidence of cardiogenic, pulmonary, or systemic congestion. And in heart failure, of course, there's nuances to this diagnosis because the ejection fraction will be preserved. And the natriuretic peptides might not help you as much because we know that in HFpEF, for a given level of congestion, there'll be relatively lower natriuretic peptide levels, probably confounded by the association of obesity with HFpEF, where there are lower levels. And this is actually quite delightful to me because one of the reasons I went into cardiology is because I love the history and the physical exam, and you can't forget it. It'll never let you down. And certainly in HFpEF, it's important. So let's go through the symptoms and signs. These are the Framingham major and minor criteria, which came out in the 1970s. But I tell you, I love them because they still make a lot of sense. The major criteria, the things that are very specific, and the minor criteria, things that are more sensitive. And our patient has a number of these which would meet. So yes, she definitely has symptoms and signs of heart failure. And then with so many things in medicine, you don't just look at your symptoms and signs, you look at the company it keeps. So what are the demographics and the associated conditions for heart failure with preserved ejection fraction? What milieu does it live in? Well, older people, female, hypertension, AFib, diabetes, coronary disease, obesity, kidney dysfunction. What we're starting to learn now is that we don't live in our individual silos, but there is this inflammatory, mysterious milieu of the cardiometabolic kidney axis. She's got a lot of these. And then we think of suggesting findings on echo. Now, the echo might have preserved ejection fraction, but it doesn't mean the echo is normal. There can be increased LV wall thickness, increased left atrial size related to chronic elevation of left-sided filling pressures, diastolic dysfunction, neither necessary nor specific, but can be associated, an elevated estimated right ventricular systolic pressure. Now, if all else fails, you can go to a peak VO2, a right heart catheterization. These are guidelines that came out very recently, just in July, from the American Society of Echocardiography on diastolic dysfunction grading and HFpEF. And spoiler alert, I don't use these in clinical practice. I find them absolutely confounding, to be honest with you, but they are the latest and greatest. I sort of have a rule in life that there was too many arrows, it's too complicated, and I find this to be not readily accessible for clinical practice. I think the use of right heart cath is not really entered standard practice, but if you were to go to this methodology, you would do so with right heart cath at rest. You can do passive leg raise as well as exercise. But I love the trusty H2FpEF score. I love the trusty H2FpEF score because it takes 6 clinically readily accessible variables that are clearly very common and puts them together in a very easy score, which then can lead to a probability. So if we took our 72-year-old woman with her multiple comorbidities and her dyspnea and edema, and we put her score into the H2FpEF calculator, we get a score of 8 and a greater than 95% probability of HFpEF. Pretty straightforward. And then we'd say, well, what about other things? And, if you're not sure of the diagnosis and your H2FpEF score is intermediate, you do have the option to go to these other modalities. But by and large, your H2FpEF score won't let you down. So all of this seems very straightforward, right? Dyspnea, edema, preserved ejection fraction, walks into your office, do my H2FpEF score, and everything's going to be fine. But let's tweak the patient a little bit and see what happens. She's still a 72-year-old woman, but now she has a more indolent history. It's been going on for a few months. She has some fatigue in addition to her shortness of breath. She doesn't have hypertension, but she does have paroxysmal AFib, bilateral carpal tunnel, spinal stenosis, peripheral neuropathy. Her medications no longer include the antihypertensives and the NSAIDs. She is no longer obese or hypertensive. Her JVP is a little higher and her echo looks exactly the same. So if I gave you this patient and I said, what's the most likely diagnosis? You would say, well, there's something that smells funny here, something that smells like cardiac amyloidosis. But if you went to your trusty H2FpEF score, all things being equal, you'd say, but she still has a pretty high probability of HFpEF. So what are we supposed to do here? And I do this exercise to illustrate the challenge of the diagnosis of HFpEF, which is that it is a diagnosis of exclusion. There's no test that's going to stand up and raise its hand and tell you I am HFpEF, which means it's the hardest diagnosis to make. So when you have that patient with dyspnea, edema, and preserved ejection fraction, you have to ask yourself, could this be a restrictive cardiomyopathy, a hypertrophic cardiomyopathy, valve disease, right heart failure, obstructive lesions, pericardial disease, high output failure? The good news is an echo will rule out most of these other things, and your history will never let you down. And it's so important to look for these other causes. Otherwise, you may deny the patient disease-modifying therapy that could improve their outcomes. What are some clues that tell you it's not HFpEF? If they don't have that classic milieu of the inflammatory cardio, kidney, metabolic comorbidities, that's often a clue. Also think about the rhythm of their disease, right? Every disease has a rhythm and a trajectory, and the longer you live in medicine, the more you internalize those rhythms and trajectory. So HFpEF is typically a disease of relative quiescence, punctuated by discrete exacerbations with identifiable triggers, like, yeah, I'm always a little short of breath, but then I took an NSAID and whoa, I ended up in the hospital. As opposed to cardiac amyloidosis, which typically, TTR, will have a slow but inexorable progressive decline. So pay attention to the rhythm and the trajectory of the patient's presentation, and then pay attention to that QRS voltage. Does it fit what the echo is telling you about the wall thickness? So dyspnea, edema, preserved ejection fraction. Question number one, is it the heart's fault? Or is the congestion actually coming from a different organ, kidney, liver, venous insufficiency? It's very hard to unring the bell of misinformation. And once the patient has been told they have heart failure and they come to your office and you attempt to disabuse them of that notion because it's actually their kidney's fault or their liver's fault, that can be difficult. So we try to make the first diagnosis from the start and focus our energy on the right organ. But if it is the heart's fault, then ask yourself, is there something else going on? Amyloidosis, HCM, pericardial disease, valve disease, high output heart failure, for which there might be disease-modifying therapy to improve their outcomes. But and if it is HFpEF, you're not done yet. You must pay attention to all those comorbidities. Now, I'm never one to advocate for more testing, but I'll always advocate for more thinking. Think about the pattern of the patient's presentation and does it fit? And then just the brief foray on how you're going to know it's cardiac amyloidosis. As we all know, it's a condition where there's an abnormal protein that decides to infiltrate the myocardium, resulting in a restrictive cardiomyopathy. The two most common forms will be immunoglobulin light chains, AL cardiac amyloidosis along the spectrum from MGUS to multiple myeloma, and the TTR protein, which can in turn have one of two sources of mutation in the gene. That's the variant form, or the wild type gene, which we used to call senile cardiac amyloidosis in the olden days, and we don't do that anymore. It hurts people's feelings. Now we call it wild type and variant. And remember, this protein just doesn't go to the heart, it goes to other places as well. There can be a neuropathy, a nephropathy unique to AL, gastrointestinal involvement, orthopedic issues. So amyloidosis requires a high index of suspicion. Your heart failure symptoms are but the tip of the iceberg. Be aware of what else lies beneath those other cardiac findings. And note that in one case series of older patients admitted with decompensated HFpEF routinely screened for cardiac amyloidosis, 13% had cardiac amyloidosis. Be mindful of that diagnosis. Think about things like the sensory neuropathy, autonomic dysfunction. How does autonomic dysfunction present? You have an older patient with a little bit of hypertension. You put them on a little bit of a vasodilating antihypertensive, and a week later they say, I faint every time I stand up. That intolerance to vasodilators is a clue. Think about the carpal tunnel, spinal stenosis, which can precede cardiac involvement by 5 to 10 years. So when you go back to that patient who I tweaked, it totally jumps out at you. And so much of medicine is pattern recognition, taking seemingly disparate findings, leading to a satisfying, unifying diagnosis. 10 years ago, if you'd asked me, what do you think of this patient with dyspnea, edema, and carpal tunnel? I'd be like, why do I care about carpal tunnel again? But that's the beauty of medicine, right? We have to incorporate the evidence and the knowledge to make us better diagnosticians. Okay, that is my brief foray into amyloidosis because I never want you to forget about it when you're seeing a patient with dyspnea, edema, and preserved ejection fraction. But now we'll go back to HFpEF and management. So which of the following is recommended for a treatment for HFpEF? Lisinopril, furosemide, metoprolol, ivabradine, digoxin. So of course, on this list, the only thing that actually works is furosemide. And why do I show you this? I show you this because for so long, HFpEF has been the great white whale of cardiology. HFrEF is so lovely, isn't it? It has such, it's a triumph of translational medicine, where our understanding of tiny molecules, like Dr. Gelfand Sr. understands, not like anyone, and not that I understand, but an understanding of those tiny molecules has translated into pills that help our patients feel better, live longer, stay out of the hospital, and maybe improve their EF. Right? Pathophysiology makes sense. And because the pathophysiology makes sense, the treatments work. Let's contrast that with our understanding of the pathophysiology of HFpEF. Now, I'm going to apologize in advance to the true HFpEF expert in this room, Dr. Ho, but this is, I'll tell you my understanding of the pathophysiology of HFpEF. And my understanding of the pathophysiology of HFpEF, I liken to that parable you might know about the blind men and the elephant. So the parable goes that 6 blind men encounter an elephant in a field. And they all encounter the elephant coming at them from different angles. And so one is by its tusk, one its trunk, one's its ear, his side, its tail, its leg. And so they try to convince each other what an elephant is. And they'll say it's a fan, spear, snake, tree, wall, rope, because they only see one part. They don't see the whole picture. And I would say that many of our observations of the pathophysiology of HFpEF follow this parable. We know there can be diastolic dysfunction. Yes, there can be chronotropic incompetence. Yeah, the vasculature doesn't work quite well. The skeletal muscle is a little off. The endothelium doesn't work right, the RVs. But all of how these fit together and how these phenotypes differ is my sense of why we've had such a difficult time finding therapies that work for this condition. And why, when we think about HFpEF therapies, that many of them did not work. And many of the ones that didn't work were things that were translated from HFrEF to HFpEF with little evidence of benefit. And I've been giving this talk now, gosh, for probably about 10 years. And what's so exciting to me is how I've been able to move more things to the meh and the wow category as the years. In fact, there were no wows actually as of 10 years ago. So this is a very exciting time to be a cardiologist. It's very exciting to see patients with HFpEF and actually have something to offer them. So let's talk about the data and my take on the data and what you should give your patients. Let's start with the story of spironolactone. So spironolactone, as we all know, is a mineralocorticoid antagonist tested in the TopCat trial over a decade ago. Symptomatic HFpEF randomized to spironolactone versus placebo did not meet its primary endpoint of a reduction in cardiovascular hospitalizations and death, or heart failure hospitalizations and cardiovascular death, but did meet its secondary endpoint of a reduction in cardiovascular hospitalizations and an expected bump in potassium and creatinine in those patients receiving spironolactone. So when this trial came out, many of us were very sad because it was supposed to work and it didn't work. And why didn't it work? So then the genius clinical trialists took a deep dive into their data and they said, wait a minute, something is very funny with this data. It was an international trial, and half the patients came from the Americas and half came from Russia and the former Soviet state of Georgia. And there was something very odd about these patients from Russia and Georgia. First odd thing, they were mysteriously healthy for HFpEF patients. Their event rates were in the 2 to 3% as opposed to the 20% range. other mysterious thing is when they were ostensibly receiving spironolactone, they didn't have a bump in their potassium or creatinine. They didn't have metabolites of spironolactone in their urine, which makes one think of some nefarious goings on where half the people enrolled in the trial might not have had HFpEF and might not have received study drug, which made the trial as a whole a total wash. But we must go back to first principles, and subgroup analyses are inherently hypothesis generating, and that is why the 2022 heart failure guidelines gave mineralocorticoid antagonists a class 2B indication. But I felt in my heart, and I think Dr. Ho felt in her heart too, that this worked, and we were giving spironolactone to our patients. Because we are stalwart, and we are loyal, and we trusted the data. And then it took a decade, however, for us to see some evidence that proved that MRAs work. Fine Arts Trial, 2024. Finerenone, a different mineralocorticoid antagonist, now in patients with symptomatic HFpEF, finerenone versus placebo, met its primary endpoint of a reduction in cardiovascular death and worsening heart failure, driven as expected by worsening heart failure. Super exciting. So the question becomes, if finerenone, spironolactone, different, do we care? According to the authors of the New England Journal article, finerenone is distinct in that it's a non-steroidal mineralocorticoid receptor antagonist with physiochemical properties that are distinct from spironolactone: balanced distribution, short half-life without metabolites. Do you see me waving my hands? I'm kind of waving my hands because do we care clinically about these physiochemical properties? Is this a triumph of finerenone or is it a vindication of spironolactone? So when I don't know the answer to a question, I often go to Twitter and ask my closest friends what they think. In fact, dinner last night inspired a Twitter poll. I'll go look at it because it was Dr. Rao who brought up a question and I put it on Twitter and you guys can all vote and see what you think. It's not about HFpEF, so I won't get into it now. But okay, so finerenone, which is better? So I put it on Twitter and I said, Fine Arts, Top Cat, which MRA will you use? And look, it's like the cardiology community, or I don't know, random people on Twitter don't really know. It's kind of evenly split. So I'll tell you my take. One of my rules in life is that perfect is the enemy of good. So yes, you can be perfect and give finerenone, especially if your patient has diabetes or CKD, which are other trials showing benefit. But if they're going to mortgage their house to pay for it, then spironolactone is good enough. So I really think that's the best way to balance this data. So that's a mineralocorticoid antagonist, very exciting story. Now let's move on to a equally exciting but less controversial story, that of the SGLT2 inhibitors. How lovely. We have two trials, Emperor Preserved and Deliver, that both in about 6,000 patients with symptomatic HFpEF met their primary endpoint of a reduction in heart failure hospitalizations, cardiovascular death, better kidney function when you give them. This is very nice, right? This is very clear. Two trials. Primary endpoint met. But then you look at the heart failure guidelines. You're like, why is it a class 2A indication? Why isn't it a class 1, AKA put it in the water? Well, the reason for that is because at the time the 22 guidelines were published, only one of these trials had come out. And the writing committee had felt, gosh, if we only have one trial and not two, and the second one's pending. But I think we should all in our minds consider this a class 1. This is a class 1 SGLT2 for all your patients with HFpEF to help them feel better. The ARNIs, okay, now we'll go back to something a little controversial. So what about the ARNIs? Now we know for HFrEF, considered a game changer. In HFrEF, knocked the ACE inhibitor off its throne. But what about in HFpEF? Well, the Paragon HF trial did not meet its primary endpoint of a reduction in cardiovascular death and heart failure hospitalization. It also did not meet its secondary endpoint of a reduction in heart failure hospitalization. But internet pundits across the globe said if there'd only been 7 more events in the placebo arm, it would have been significant. But there weren't 7 more events in the placebo arm, so it wasn't significant, and wishing doesn't make it so. And the subgroup analysis is really compelling here. You see that there's this benefit if your EF is on the lower end of the spectrum. You see a benefit in women versus men. Isn't that tantalizing? Do we need sex-specific threshold for EF? Is what we consider normal in women not really normal? Is that why this signal exists? Probably. But subgroup analyses being inherently hypothesis generating means that it has a relatively weak 2B indication. So how do I think of this? Perfect is the enemy of good. So MRA, SGLT2, super important, good data, got to give them. Then your patient still has high blood pressure, as they are wont to do, and they can afford an ARNI, put them on an ARNI. They, especially if they're a woman, because they are certainly not going to be harmed and they will likely derive benefit. ARBs, again, if they can't afford an ARNI, can you give them an ARB? Well, the CHARM trial came out, oh my gosh, over 20 years ago now, and did show some benefit. Other analyses didn't corroborate this, so it has a weak indication. So I put it kind of next to ARNIs, which I have an excuse to give something for blood pressure. ARNI would be the best option. If they can't afford it, let's give them an ARB. And of course, no talk about HFpEF would be complete without a discussion of exercise and weight loss. I love this bar graph on the left. Let's focus on this very cool study. 100 patients with HFpEF, average age 67, average BMI 39, were randomized to either calorie restriction, cut out 400 calories a day, or aerobic exercise training 3 times a week, basically cardiac rehab, and said, what happens to your peak VO2, your function? What happens to your quality of life, your feel? And both feel and function improved. The forest plot on the right as meta-analysis of supervised exercise trials and supervised exercise randomized trials, and showed again that patients have improved feel and function with exercise training. And if I was giving this talk a few years ago, this is where I would say, gosh, but it's really hard to help people lose weight. And cardiac rehab isn't covered for HFpEF. So just do your best to help your patient. But because medical science marches onward, I can now say that, in fact, we have other things that work, including the incretin-based therapies. So these magical and mysterious agents, GLP-1, GIP receptor agonists, that don't just lower blood sugar, but also work on the heart and work on the brain and work on who knows what other organs to help people effectively lose weight. So where do they fit into our armamentarium? So the first data came in the STEP HFpEF trial 2 years ago. 500 patients with HFpEF and a median BMI of 37 randomized to semaglutide versus placebo for a year, better quality of life, walked farther, 6-minute walk distance, more weight loss. So everyone was thinking, well, is this actually beneficial in HFpEF, or is it just an effective way to lose weight, which helps everybody feel better and function better, including those with HFpEF? And there was a really nice meta subgroup analysis published simultaneously with the original New England Journal article that stratified the findings based on degree of weight loss. And yeah, the more weight you lose, the better you feel and the better you function. So everyone was hungry for heart failure endpoints. What about clinical endpoints? And that was answered to some extent, that's foreshadow to some extent, in the SUMMIT trial. The SUMMIT trial looked at tirzepatide, a dual agonist, in patients with HFpEF, BMI 30 or more, tirzepatide or placebo, and they had this endpoint. Their initial endpoint was just really supposed to be feel and function, but then they're like, oh, wait, the STEP HFpEF trial was positive. Let's pivot. Let's look at clinical endpoints. And they looked at cardiovascular death and worsening heart failure. And in fact, patients did better on tirzepatide. There was less death, worsening heart failure driven by worsening heart failure. There was better KCCQ scores, meaning better quality of life. There was more body weight reduction, no surprise. So the trial is positive, but I'm giving you all the body language to suggest I'm not that excited about it. And I have tempered enthusiasm for this trial. Now, worsening heart failure is a funny endpoint, defined as exacerbated symptoms resulting in hospitalizations, IV therapy in urgent care setting, or intensification of oral diuretics. I don't know. That last one bothers me a little bit. I think it's rife with potential for confounding. And if you look at the events that we really consider actual objective worsening heart failure, hospitalizations, there was a very low event rate. I don't suspect the FDA will ever extend the indication of tirzepatide to include HFpEF based on this trial, but that's okay because the trial is still very important because it tells us, number one, clearly safe in HFpEF, clearly effective to help these people feel better and live longer. And you know what? Your patients with HFpEF will guarantee have another indication to take a GLP-1 GIP receptor agonist. So who is a candidate for these therapies? So we know that they are FDA approved if you have cardiovascular disease and either obesity and overweight, or weight-related comorbidities like hypertension, diabetes, as well as diabetes, sleep apnea. We know the benefits based on clinical trials are these patients who have heart failure with preserved ejection fraction, symptomatic, though those would not be FDA-approved indications, though these patients would likely meet FDA-approved indications. We use them with caution if the EF is low. Why is that? Well, we know from subgroup analyses of trials that if you have patients with a low EF, there are more arrhythmic events, and in meta-analyses, increased heart failure hospitalizations. But you know what? This is why I hope AI will never take our jobs. There's still room for clinical decision-making and shared decision-making. So if I have a patient who with advanced heart failure and a low EF, whose body mass index prohibitive for heart transplant listing, and isn't a candidate for an LVAD for whatever reason, it is actually terrible to help with weight loss, actually, even though it's often used for that indication, I will have the discussion with them that I think you're more likely to die of advanced heart failure than a complication of an incretin-based therapy. And if we can get your weight down, you can be listed. So I think there's room for nuance there. So when you're going to give incretin-based therapy to your patient with HFpEF, of course, common sense. You want to confirm their stability prior to initiation. You want to tell them how to inject it and all that. And because the titration happens every 4 weeks, I think it makes sense to see them every 4 weeks, monitor for the GI adverse effects that may affect their fluid balance. I think it makes sense. This isn't a package insert, but to check a basic metabolic every 4 weeks just to confirm everything is stable with any changes in oral intake. And of course, be very aware of the absolute contraindications or the concerning side effects like pancreatitis, gallbladder disease, and any thyroid symptoms. But, I was so excited when these things came out and I said, everyone's going to take them. And now all of our airfare is going to go down because people on planes aren't going to weigh as much and it's going to be so amazing. But, clinical trials aren't real life. And I really love this analysis of over 100,000 patients who had an indication for one of these therapies for obesity, looking at electronic medical records, and the discontinuation rates were awfully high. So don't beat yourself up if you put a patient on one of these and they can't tolerate them. I think there is a learning curve of how to counsel patients for the side effects, particularly gastrointestinal. Finally, let's talk about the comorbidities. We know that all these patients have hypertension, diabetes, obesity, which leads to CKD, sleep apnea, CAD, and AFib, which can culminate in HFpEF. And how do you treat them? Well, you guys are good doctors. You know that rate versus rhythm control really is guided by symptoms. You avoid aggressive rate control because they have that low stroke volume of their stiff HFpEF heart and anticoagulation. You keep their blood pressure down, and you remember you have a 2-for-1 for blood pressure control if you use an MRA and ARNI or ARB, as there's also clinical benefit in HFpEF. CKD, you'll manage per guidelines. And, diabetes is in a renaissance now with all these intersecting therapies like SGLT2s and GIP receptor agonists. CKD now, I went into cardiology because I didn't really like the kidney, but look, everything comes full circle. And now we have to understand how our therapies can be kidney protective. They're even stealing our pillars now, right? And applying them to chronic kidney disease. Sleep apnea, while there's no data that treating sleep apnea will improve heart failure outcomes, it will help your patient feel better. And that's a very worthy goal. So be aware of the daytime somnolence, daytime headaches, snoring, body habitus that will lead you to polysomnography. And then now, of course, obesity, we're in a brave new world. So, as I said, one reason when I was in medical school, right, I was like, please don't give me one more fact. I do not want any new things to come out ever because I'm having a hard enough time learning the facts I'm supposed to learn. I remember I was sitting in the medical school library one day, despairing, because this is back in the olden days when you actually sat in the library and like looked at books and took notes. And I just randomly looked up at the wall of the medical school library, and there was a 3-volume set of the cornea. And I was like, it's 1 cell thick. How can they have a 3-volume? And that's when I said, I'll never know everything. This is really depressing. But I soldiered on. And now, isn't it wonderful to be out of training and to actually enjoy new facts and say, I'm excited that I have new things to learn and apply to my patients. Maybe the kids today don't feel that way because you have ChatGPT and open evidence. But in any case, this is super exciting. And when it comes to managing our patients with HFpEF, the one thing, the 2 things you got to know as a doctor is sick or not sick. And you don't have to know all the answers, but you have to know what questions you have to ask and where to find the answers. So it takes a village. Also, I have 3 kids. So if anyone has any help with that, please let me know. But the village, when it comes to HFpEF, think about the care team and how we can best leverage our care team to give the best care to our patients. And then when we think about how far HFpEF has come in the last few years, this is from the 2022 heart failure guidelines. How long ago was that? 3 years ago. And back then, back in the olden days, we're like, diuretics are a necessary evil. I don't know, maybe give the other stuff. Then we can say the 2023 expert consensus decision pathway document, SGLT2 inhibitors, yeah, you should do it. This is really important. Everything else may be a necessary evil. But you know what? Look how far we've come. Look how much excitement has happened over the last 2 years. And with that excitement, I would change the expert consensus decision pathway document to look something like this. And it's funny, I've given this talk before, and I've said this, and I've said, if anyone in the audience has any pull with the ACC, can you please let them know it's time to update the 2023 expert consensus on HFpEF? And I think I've said it enough times that the 2026 one is in the works. So that's very exciting. So HFpEF, SGLT2 and MRA for everybody. Yes, loop diuretics remain a necessary evil, but hopefully you'll need less of those with all their neurohormonal derangements they cause because you're giving an SGLT2 and an MRA. And then if they meet criteria, slap on an incretin-based therapy with the confidence of knowing it is safe and it will help them feel better if they can effectively lose weight. And then if you have an excuse because they're hypertensive, especially women, give an ARNI if they can afford it and an ARB if they can't. Oh, and yes, non-essential beta blockers. So I added that there to remind myself. It's funny, when I crafted the figure for the expert consensus decision pathway in 2023, I wanted to put beta blockers on there with some kind of like, please don't give beta blockers if you don't need them. But everyone was like, no, you can't put a beta blocker into the document because people who read it really fast will think they're indicated. So I'm like, well, how can I put it in such a way that people will really know it's not indicated? So I'm going to try to work this in. But here's the thing, right? Beta blockers are really falling out of favor. They're so it's like if SGLT2 inhibitors are Taylor Swift, then beta blockers are like Britney Spears, right? All due respect. Because they don't, unless you have HFrEF, why are you even giving them? And one of the best things you can do, if some doctor trying really hard to take good care of their patient said, well, this person had an MI and they have heart failure, and I'm going to put them on a beta blocker. When they come to you saying, I'm so tired all the time and I just can't walk and I can't do anything, and you take away their beta blocker, they think you are the best doctor in the world. So please actively deprescribe beta blockers unless you can justify to yourself a good reason to put them on. And a good reason is not HFpEF. And a good reason is not, oh, they had an MI some time ago and I don't really know when it was. Those are not reasons to give your beta blocker. Okay, so take-home messages. HFpEF is a diagnosis of exclusion, one of the hardest diagnoses to make. Echo can help. Your history is important. Think about seemingly disparate findings that lead to a satisfying, unifying diagnosis, and don't miss amyloidosis. Implement these promising therapies like the SGLT2, MRA, and incretin-based therapies. And you don't have to know everything, but you know how to incorporate your village to give your patient the best care. Thanks so much for your attention. Mhm. Mhm.
Thanks very much. We have some room for questions. Let me just ask you one quick question. You're going to be helping, I'm sure, or leading the next consensus writing group. Is it time to move away from ejection fraction in general? I mean, you gave a beautiful talk and you mentioned ejection fraction a couple times in the beginning and out of necessity once in the middle. We're still very tied to the ejection fraction. And what would the new sort of pathophysiology-based definition look like, and how would that change guidelines and management?
I think if we are beholden to clinical trials to guide our therapy. So I think of ejection fraction kind of like I think about BMI. So ejection fraction for heart failure, BMI as a necessary evil that has been the basis and the foundation of so much of what we do. And I do think it is important in the sense that HFrEF is a different animal than HFpEF. Now, God bless HFmrEF. I don't know. I don't know why a 9-point category has got its own title, but I think of 40 as the magical number. If you're less than 40, you have this unique physiology of these neurohormonal axes where RAS inhibitors, ARNI, evidence-based beta blocker, MRA, SGLT2 inhibitor will help you feel better, live longer, stay out of the hospital, and 30% of people, at least with non-ischemic cardiomyopathy, will improve their EF with those therapies at maximum doses. But then I think about above 40, it is its own thing. Remember, they're stiffer, they're a bit restrictive, they don't typically tolerate the vasodilation or the beta blockade due to their fixed stroke volume. So I still think unless and until different clinical trial criteria are put in place for which we can guide therapies' effectiveness or benefit, it is here to stay. And the pathophysiology, I think, is different. And you didn't ask about BMI, but that's a tough one too, isn't it? We all know it's not the best measure. It's different. You can have a different body habit. It's a different ethnicity, a different race, and it doesn't quite fit. It doesn't reflect fat deposition only. Waist to hip ratio is probably better. Other anthropometric criteria. But until the clinical trials that demonstrate efficacy and benefit use other criteria, I think we're stuck with BMI. So I think it's in that way still a necessary evil and also insight into pathophysiology. Mm.
I was wondering what your thoughts were for the non-congested PEF patient and whether those who, the diagnosis is made only with exercise hemodynamics. Is your treatment algorithm the same? Are you focusing more on specific comorbidities in that patient, for instance, obesity, which many do have?
Yeah, so I have to say that I think for me, so I showed you the right heart cath algorithm, but how many times have I ever used a right heart cath in purely clinical practice to diagnose my patient? Because why are they going to come to me? They're going to come to me because they have symptoms. Symptoms started this whole thing, right? They had shortness of breath and their internist sent them to a cardiologist. So, and then I'll look at them and say, gosh, you meet all the comorbidities, my clinical gestalt or my amyloid, diagnostic criteria. You don't seem to meet those. I think you're a garden variety HFpEF patient. You have shortness of breath. There's no test that's going to stand up and wave its hand and tell me that you're it, but your HFpEF score is good enough. The question is, what do I do there? Do I do a right heart cath? No, I typically don't. I tend to be more pragmatic and expedient and say, listen, if you're short of breath from HFpEF, there's a few things that are going to help you feel better. Loop diuretics is a necessary evil for congestion, but let's start by initiating an MRA and an SGLT2 inhibitor. That should help you feel better in conjunction with, let's control your AFib. Let's work on your weight loss. Let's make sure there isn't angina from your coronary disease contributing. So I think these patients are typically only going to come to you for symptoms. And if they come to you for symptoms, we know that the beauty of the MRA and the SGLT2 inhibitors, they don't just prevent hospitalizations, they also improve symptoms. So that is why I think the goal really in these patients with multiple comorbidities who are older really focuses on the symptom management. Does that answer your question? Yeah. Yes. Yeah. Yeah, but then you think, Yeah, but the MRA, but then I guess the MRAs and the SGLT2 inhibitors, well, if you got a little diabetes, they're probably going to be good for you. You got a little kidney disease, they're going to be great for you too. So let's sprinkle them around. There's going to be more benefit than harm. Mm-hmm.
Lovely talk. Quick question. So you mentioned the biomarker. You ever check it in to tell you which therapy efficacy? I didn't seem to suggest it did.
Yes. So all due respect to the pioneering research that many people do with biomarkers, I do not use them in clinical practice. In fact, I don't even check. I don't ever check natriuretic peptides. I feel like I should duck when I say that. Maybe I apologize. I'll tell you. I'll tell you why. I think for a patient who shows up to the ER and nobody knows what's going on with that patient and they don't know history and you check a BNP because you just want to know, how do I stratify my differential? I think that's hugely helpful, with the caveat being if they're very overweight, it might be low, so it doesn't help you fully. But for me, listen, Dr. Lynn Warner Stevenson taught me how to diagnose, how to check a JVP. I really think that the history and that targeted physical and the empiric use of these decongesting therapies that have other clinical benefit is helpful. And I think checking any biomarker in a vacuum is a terrible thing to do. And there's also data to show serial assessment of BNP to guide diuretic therapy has not been proven beneficial, because I think there's just too much wavering of the baseline. And it's like it's not as bad as a CRP, but it's like how many things are factoring in to my BNP. So no, I think titrating your therapy to the patient's history and physical is the best approach. And when other doctors check the BNP and the patient messages me frantic about the results, I have a little smart phrase I put in: this result is not medically relevant and not going to change your management. You can copy it, feel free.
Thank you. This was an amazing talk. And I love the fact that you go back to the history and physical really drives everything. I guess I'm curious to hear from you whether you're sort of a lumper or a splitter. I feel like there's recently been this adipokine hypothesis that attributes all of HFpEF to adipose tissue and sort of the downstream effects. I also feel like the management now is sort of like, we can treat everyone the same. Do you feel like there's opportunity to treat everyone the same, but then also maybe understand nuances behind different factors that drive disease? And how do we think about targeted therapies in the future?
Amazing. Oh my gosh. Well, to say Dr. Jennifer Ho thought my talk was good is very cool. So thank you for that. I hope this is recorded. So I think it's so, isn't it? So let's think about HFrEF for a second. How lucky did those guys get in the 1980s, right? They just threw a therapy at the wall and, spaghetti at the wall and it stuck, right? Isotyl hydralazine, sure, it works. ACE inhibitors, like they didn't even quite understand the neurohormonal hypothesis, yet all these therapies worked. And it seemed like a very homogenous disease. Contrast that with HFpEF. As you said, it is not homogenous. It is not all created equal. It is actually delightful, I think, to at least have two therapies that seem to work universally, the MRA and the SGLT2 inhibitor. And then if you're obese, the incretin-based therapies. But that's so, and I think that speaks to the fact that pacing, we don't know if it works. Maybe we don't have the right population, or the interatrial shunt devices. If you have a primary left atrial hypertension physiology, maybe it doesn't work because we haven't phenotyped them well enough to figure it out. So I totally agree with you. Or women, maybe their EFs are just different, and that's why. So I think people like Dr. Ho are going to do the amazing research to better phenotype these people, to better targeted enrollment in the clinical trials to get therapies that work. But until that happens, it's kind of relieving to have these other things like the MRI, the SGLT2 inhibitor, and the incretin-based therapies that seem to work across the board. Do you agree with that? Okay, amazing.
Thank you for a great talk. To return to sort of the role of symptoms in the titration of your therapy, I'm curious to know if you see more of a role of the KCCQ or other type of sort of patient-reported outcomes in clinical practice, or sort of the reliance on NYHA. And I think of the older patient who maybe doesn't do as much, and sort of how are you teasing out, how effective your titration? has been.
Yeah, I say, how are you feeling? And do you feel as good as you want to feel? What are you doing for exercise? Why aren't you doing more? Right? Because that's really the key. If they tell me, I walk 30 minutes every day, and since you started my MRA and SGLT2 inhibitor and I lost 20 pounds, and I'm only limited by my knee, I say, congratulations, we have won the game. If they say, I try to walk 15 minutes, but you know what? The shortness of breath gets me before my knee starts hurting. I'm like, okay, maybe we have more work to do. And I think, HFpEF is on that spectrum of restrictive physiology. That's for amyloid being the classic of that. So I tend to titrate diuretics not solely to my physical exam, but to relief of symptoms. It's also tricky in these older patients. Even when they don't have amyloid, they have some autonomic dysfunction with orthostasis, vulnerability to symptomatic orthostasis, which can lead to falls and injury. So I kind of empower them. I'm like, the MRA and the SGLT2, you just stay on those, but I empower you to play with your loop diuretic. It's not a set it and forget it med. It's, I feel a little dry today. I feel a little wet today. And that can often be helpful for them to do better titration to symptom relief.
Michelle, great talk. You alluded to some of the data from Delane Kitzman and others around exercise. Can you talk about, is there room, where do you see that in the formal guidelines? And is there a potential play for getting cardiac rehab covered for HFpEF, which is something that drives us nuts?
Yes, I also say that in every talk I give, hoping that someone from the Center for Medicare and Medicaid Services is going to listen and champion it. It has not happened yet, but you never know. I know the AHA has for years been writing some sort of policy statement to give to some sort of government body to try to get it extended coverage for HFpEF. I know because they've asked me to review it a few times, but I don't know where that is in the process. In the meantime, shout out to the awesome Dr. Nancy Schweitzer at WashU, another HFpEF expert who has the most practical advice I've ever received on how to tell patients to exercise. Honestly, I should put it in a slide and give her credit at the bottom. And she tells patients basically three things. Number one, you only have to exercise on the days you eat. It's not bad. Number two, yeah, that's great. She's great. You have to start where you can and recognize you will be short of breath. Your physiology of that stiff heart and you're going to be short of breath. So you just walk until you feel short of breath and go one more minute. And then every week you try to increase it a little bit. And just that practical guidelines can kind of help them do their own type of supervised exercise training. So that's something I've incorporated into practice as well.
This is a question that's on all of our minds. What was Eli like as an intern?
Okay. Yes, I'm so glad you asked. So you know how when... No, I'm well aware. I met the esteemed Dr. Gelfand. So, is there something magical, I think, about being co-residents together, that relationship is totally forged in fire, and it doesn't matter how many decades it's been since you last see them. We're transported back to the BMT service, handwriting our notes every morning, and or me telling him, Eli, you better get your notes done. No, he was always good about getting his notes done, and an absolute superstar who has reached the greatest heights I would have imagined for him.
It's always a little trouble for people who fly, because I don't know if it's going to fit in your carry-on. So perfect.
Yeah, thank you so much.
Thank
in
you.
fact, the TSA, I'll be like, do you want to see my prescription?
Yep.
Thank you. Oh my gosh, that's awesome. Thank you so much.
Even with Stan. Okay, good. Thanks everyone for coming.